Now I'd like to introduce our next speaker, who is Keith Bodger. It's really a great pleasure to introduce Keith. He's, in a world of busy men, extremely busy, working as a full-time clinical gastroenterologist, but also within the Department of Informatics at the University of Liverpool as a health economist. And he's found time to become involved with the IBD Registry in coordinating the analysis of data, and many of you will have seen the first of the annual UK IBD Registry reports landing in your desks, comparing local performance of participating trusts with national benchmarking. So it's a particular pleasure, Keith, and I know he's actually in much demand. He's going to be zooming off fairly soon afterwards to give another paper, but he's here with us now to talk about learning from IBD Registry and NHS data. Keith, thank you.
Thanks, Stuart, and thanks for the invitation. So I'm going to talk about two aspects of data that the registry has tried to provide to essentially start at least a nudge towards a learning healthcare system for inflammatory bowel disease, and much of the permissions and the technical aspects and the considerable difficulties in moving this forward were pioneered by Richard Driscoll's involvement in supporting and taking on some of the many quite difficult challenges in setting up the registry and the data permissions. So I'll talk about the registry data, which is finally starting to accumulate and becoming reportable, but also about the additional data that the registry has secured permissions for, again, through Richard's sterling work, to provide analyses of routinely collected NHS data. So I'll get the acknowledgements in first. Much of this work was funded by a grant from Crohn's Colitis UK to start improving and helping the analytical side, and we've been essentially servicing the downstream data that's been flowing from the registry. This is a nice picture of Richard, happy day, with Mustafa, who's a key player in this. Much of the analysis you see today, Mustafa's in the audience, so the two key players. So focusing on the data collected by the registry teams locally, it's been a struggle, hasn't it? It's been difficult and challenging, and many bear traps along the way. This is a quote, and it's about patience and perseverance, and not abreacting to the issues, but actually getting on and doing the positive stuff in a calm and measured way. And that's very much how Richard Driscoll operated, and something I've learned from my time working with him on this challenging but rewarding project. So patience is a virtue, and the registry is growing, and this is the footprint now of contributing sites and centres. So it is growing in that time scale, doubling of sites contributing and submitting data. Yes, there are issues and one or two local problems with software to get the data through the system and reportable, but that's all fixable. The number of patients registered has grown, actually now to over 40,000 patients at the latest download. The number of patients on biological therapies with data that's run through the system is now in excess of 7,000. So what are we learning from the data? Well, of course, it's dirty data. It's not necessarily of research quality, but it is building. And as sites are quite clearly now establishing live biologics registers, we're starting to learn about new initiations of treatment. So this is the profile of Crohn's patients naive to biologics who were started in the period from April onwards. This is not all the data. Actually, there's some sites where there's data needs to be collected and brought into the system, but this is a profile. We now know that on average, median time from diagnosis to initiation of treatment, 3 years in this registry cohort. 50%, or roughly half, are on combo therapy. We're now getting serial data collected and submitted on outcomes. So simple things, a physician global assessment, but it's better than nothing. And so we know that the initiated patients were judged moderate or to severe by initiating clinicians in 85% of cases starting biologics in this cohort, and the post-induction review, only 27%. And Harvey Bradshaw scores have been collected, not on everyone, and that's still work to do, but when they are collected, a halving of median scores, and 62% in remission in this real-world data cohort. Collecting data serially has been a major challenge, but trying to push forward and support participation in national audit has been a key drive for the registry. Many difficulties and challenges with this at all stages, but this has grown, and the recent reports issued have shown that it is now possible to collect and report on data to support the audit. There are some centres that haven't received the data because there are some glitches, I understand, at the afferent end. The data feed end will be fixing that. But this is 2 consecutive uploads of the data that has been provided to us in Liverpool to provide some, at least pilot data, about benchmarking against key performance indicators for biologics and some serial data. So a proof of concept that it is possible to use the system, albeit there are some problems to iron out and report on data nationally. A key aspect of the registry's success, and I think going forward a key area for focus, is the patient engagement. And this talks a little bit to the previous presentation on research, which is when patients are asked to contribute to the registry, not only do they buy into the registry concept overall, but they're very keen to take part in research. We're running an NHR portfolio study at the moment to really try to unpick that. What is the proportion of patients when approached the registry would wish to participate in research and have their anonymised data used, but also would be contactable for future research so that sites can build local registers of patients who have already opted in to be contacted for research. And it's 95, 98% so far of patients who will sign up to all options. What about routinely collected data? Well, we've been producing reports based on HES data nationally, activity reports looking at patients admitted as emergencies, starting to produce some national metrics, so the rates of surgery during emergency admission. We now got some insight into that nationally. Mortality, thankfully low. Readmission rates. We produced some national trends and shared this with participating hospitals, so we're looking at national trends and benchmarking. We're now able to produce some benchmarking reports and funnel plots to start to unpick variation across trusts, and this is surgical rates. Mortality, there's a good news story here. We've looked at not only 5 but 10 years data. The risk of dying in hospital from ulcerative colitis over the last decade has genuinely fallen, and after all sorts of complex modelling, these crude data are borne out. So there's a good news story in the national data. But no outliers. So the hospitals we've analysed, there aren't any high mortality outliers. Mortality is very sensitive, but what we're seeing no signal that actually, by and large, mortality is flat when you pool 5 years of data for all hospitals in the country. We've also tried to unpick some of the complexities of HES data. It's of course fraught with difficulties, and much of the data you see in either local reports produced by your business intelligence team or in sophisticated looking sort of suppliers of HES data just looks at the primary diagnosis, and yes, you get a sample of patients, and yes, that data is useful and interesting. But of course, IBD is a complex disease, and unpicking the complexities of coding and trying to give some real sense of what the burden is, actually measuring the beans correctly. We put a lot of effort into that and produced reports where we've looked at whenever a patient is admitted with a patient with inflammatory bowel disease is admitted from this HES cohort, and provided sites with activity data related to the totality of admissions for their patients with IBD. And you can see that, look, just focusing on the primary diagnosis, yes, it's important, but there's an almost equivalent number of admissions that are often under the radar. If we really want to look at activity and planned services, we need to understand this. What about linking the data together? And finally, so the registry has obtained permissions to link data both from locally collected, granular, detailed data submitted to the registry and the HES. Now, of course, you have to wait a year or two for the HES to feed through, but we've established the techniques to analyse, for example, admissions before and after a start date for biological therapy. When we presented this about 18 months ago, there were 217 patients in this cohort. There's now over 6,000, so it should become genuinely possible to provide sites with some linked data for their efforts in recording biological therapy patients. So in conclusion, this has been a major struggle. Certainly much of the success rests on a small number of people, and particularly Richard Driscoll, helping to establish a data set, driving through the IG permissions, getting the infrastructure set up, supporting analytics reporting, and engaging a growing community of participating centres. Thank you.
Great. Okay, thank you. Sean, hello. Can you hear me? Thank you, Keith. Thank you, Keith, for that. I love the quote, "Patience is keeping going when the going is hard." I've certainly seen that a lot in recently over the registry. So thank you for that. There is opportunity for questions.